Okay, so good morning, everyone. I'm Paulo Carvalho, streaming from Portugal in Porto. We will talk today about this very specific subject. I will try to discuss a little bit on the right balance between analog and digital in modern implantology. Let me greet every one of you all around the world who are seeing this right now. We are facing incredible tough times, really harsh times nowadays, all over the world. And I would like to congratulate DU Corporate for providing this to all of you, which can be really helpful in these quarantine times to make all the time be a little bit more bearable. So I came from the most beautiful city in Portugal, which is Porto. Most of you already know it. And so today, like I said, I would like to discuss a little bit this correct balance between analog and digital. As you might already seen that nowadays there is this quite trendy theme in all the discussions about what should be digital, what should be analog, and a lot of times we see a lot of fanatic people trying to put all things in one side and all things in another side. I like to see how the two sides can complement each other and how we can get the right balance between analog and digital to get the best results and the most predictability out of it. In my experience and in my opinion, the digital tools which are quite complete nowadays. We have a wide range of digital tools that are helping us in the daily routine. It mainly gives us more consistency in our results. It makes our results more predictable, as we can do not always the procedures faster than we were doing in the past, but we are doing it in a more consistent way with always the same results, always something that we can quite expect and not only depend on our technical skills alone. So let's talk about some guided surgery concepts. It is very well known nowadays how the implant 3D position is key to the success of our implant treatments, and we perfectly know how we can experience a lot of problems, a lot of aesthetic, soft tissue, biological problems in our implant treatments when we don't achieve the correct 3D position and we don't take care of our emergence profile. So we can have this kind of soft tissue recessions, and a lot of times they are followed also by peri-implantitis issues and infection, bone loss, and we can also not only have the aesthetic problems but also lose the implants at the same time. So to master the 3D implant position, it is very important, especially when we are dealing with multiple teeth cases, to have a consistent result. Because if we are doing it for a single tooth, of course, it's much more simple to be guided by the adjacent teeth to get the proper 3D implant positioning. But what happens is that when we go for multiple teeth cases, it's not easy to always achieve this kind of results. It's not easy to have always the perfect emergence of all the implants. We should have some tools that help us to be more predictable, more consistent, because if we only depend in our hand guided brain system, of course we will be tricked, we will be fooled by the problem of dealing with multiple sites. When we deal with multiple sites, it's very frequent to see that the minimum slight deviation of the tooth axis may lead to this compression from the abutments. And when we see here close, we can see how the abutment width is compressing the interproximal tissue. And so this papilla could be longer than it actually is now. So I started my implantology by using only prosthetic guides, only multifunctional guides with only the prosthetic design of my final teeth, so I could guide my drills through these guides. But what happens is that this only relies on the mucosa, and as you may know, the thicker the mucosa is, the more mobility you can have, and especially when you have multiple sites, it's really common that you have a lot of deviations, and even implants that you might have seen that you have controlled all the drills in the protocol, you'll see at the end that you can experience some slight deviations that can be critical for the emergence profiles of these cases. Let's take a closer look at this example. You can see here how is designed the tooth axis of these two central incisors, but when you realize the outcome you had after this hand-guided surgery, you realize that the implant axis is quite different than the tooth axis. And we can say that these implants are completely wrongly placed because they are not so badly positioned, but the slight deviation, even though the screw axis hole on the palatal side is perfect, you can see that on the cervical emergence, where it is most important for the emergence profile of the soft tissues, you can see how the slight deviation initially from both teeth had led to compression again from the abutments, and you will see on the final outcome that you will never have the complete central papilla between those two teeth. And the central papilla, even though we have adjacent implants, it's always very easy to get. But in this case, the slight deviation is going to lead to compression and is going to lead to an incomplete papilla, which is not 100% aesthetically successful. That's why I try to be the most I can in digital guided surgery for multiple cases, because in multiple cases, like I said, it's not easy as humans to have always the same result, always the perfect emergence for all the implants we place on those cases. The DIO system is helping on that. It's from all the systems I have tried in the past, it offers me a very amazing accuracy in the final outcome of my implant positioning. This is the whole workflow with the DIO team. So we send all the data from the intraoral scannings and the CBCT to be merged on the system, so we can have an implant planning data. We have to confirm our implant planning, and then it's going to be produced a surgical guide as long as the prosthetic components that can also be customized for the case. But what is really important to understand is that for a correct reverse planning guided by the prosthesis, we should not only provide the CBCT scan and also and not only the initial intraoral scanning, our STL file from the intraoral scanning. We should always complement with a mock-up. We should have some kind of mock-up to the patient, whether it is an additive mock-up with a wax-up or teeth train, or you can also do some digital mock-up for subtractive cases, for example. And we should merge all these things together, not only the CBCT scan in the STL initial file, but also the mock-up file. So we need to know exactly where we want our teeth, where we'll be positioned inside the ledge, and also the margin of the gingiva that we want for the final restoration, because a lot of times we might have to reduce bone in height, reduce soft tissue, augment soft tissue. So we need to establish the proper mock-up for the case, and then after merging all these things together, we can have a proper reverse planning guided by the prosthesis. This is true reverse planning, so we can see in the same image the different layers of all this data. We have the initial STL file, the mock-up STL file already in the system, and we have the CBCT behind it. We have the bone anatomy behind it, so I can, when we plan some surgical guide, we know exactly that what we are doing through the surgical guide is going to happen in the bone according to what we need prosthetically. When we look at the literature, we can see that when comparing guided surgery to conventional hand-free surgery, we cannot say that the implant survival rates are higher or that the clinical success is going to be higher. Again, it's also a lot of there's also a lot of subjectivity on this, but we can say that our implants are going to integrate faster or better if we are doing it guided. The reason why I do it guided is because it's evident that we will have an easier and more predictable prosthetic treatment, and our procedures are much more comfort, not only for the patient but also to me, because the stress involved in the surgery are much less. So looking at the literature when talking about digital is not always fair, because the digital technologies evolve so much faster than the publishing of the literature occurs. But this can guide us in what is real, in what I really think, that it's not the success that's going to be better when it comes to implant survival rates, but it's because of the predictability of the prosthetic treatment, and because of the comfort that I get on these treatments that I can get always in conventional surgery. The DIO system is not only about a surgical guide, it's not only about having a surgical stand that allows you to put your implants in the correct 3D positioning. It is also about the prefabricated prosthetic components. You have the possibility of having, with the correct reverse planning in the correct treatment plan, to have the immediate customized abutments even before starting the surgery. And on top of those immediate customized abutments, you will have immediate customized provisionals that fit perfectly on those abutments, and you can have them already done and prepared even before starting the surgery, even before starting the anesthesia. This is quite critical. But having the connection of a prefabricated customized abutment is only possible when the deviation degree is less than 3 degrees. When it is higher than this, you will never have the proper fit of these prefabricated customized abutments after the implant placement with the surgical guide. So let's see some examples of it. This is a clinical case of a central incisor, tooth 11. It is fractured. The root is fractured, so we are going to have an immediate implant in the aesthetic area of a young lady, very demanding aesthetically. So we carefully go for the removal of the teeth. We remove the teeth very carefully, taking care of the soft tissues. We probe the buccal wall. We see that the buccal wall is intact. We check the fitting of our surgical guide. It fits perfectly on the tooth. We can see on the windows of the surgical guide how the guide is perfectly immobilized on the correct position. You have to do a very slow speed drilling, as you cannot overheat the bone. So using only 50 RPM and not more than 10 seconds of a time, you will never have overheating of the bone. At the implant insertion, is very important that you match this driver mark with the mark on the sleeve, so you are providing the correct X orientation, so that your abutment at the end is going to be connected correctly. So achieving the correct 3D positioning after the surgery, it was really easy, without any kind of effort, without stress involved. So I can focus my stress now on the mucogingival procedures that are needed, as we know that this contour is going to be restored if we don't do anything. So we are creating a tunnel, we are creating a pocket, so that we can augment with soft tissue, and then we are going to avoid the horizontal resorption that we know already occurs after tooth extraction. It's very important to get a passive mobility of the pocket. And then we go to the pellets. Here we are harvesting connective tissue for two situations. We are also covering recessions on the upper right side. So we are harvesting soft tissue for both situations at the same time. So we harvest the free gingival graft that we are going to depitalize outside the mouth. And after depitalizing, we can just divide what we need for the central incisor. This is the correct shape that we need to augment on the correct positioning. We don't need big grafts, we don't need thick grafts. For this case, it's only to preserve the contour. And through horizontal metro sutures, we can use two sutures to stabilize it and drive the grafts through into the prepared tunnel. And of course, after that, we are going to fill the gap between the implant and the buccal wall with xenograft. Again, it's not to have better bone. We are not having better vital bone, but it will help us preserve the volume intact. And with the customized abutment and the provisional that is provided already by the Unavi team, it's very easy to sit the provisional on top of the abutment at the end. I like to then convert it to screw retain so I can have it reversible. And this is after the surgery, and then after all the process of healing, we prepare the adjacent teeth for veneers, and this is the whole aesthetic treatment with the implant crown and zirconia and ceramic veneers in the adjacent teeth. This is a work by Pedro Brito, which is a very talented Portuguese ceramist. And this is also possible in full arch cases, in multiple cases. In multiple cases, it's important that, for example, in a case like this with a large extent of mucosal support, as the ridge is really wide, I'm not worried with the position at the bone, but I'm worried with the position between the implants, so I can have the proper splitting at hand with my customized provisionals. So I start with one implant, and with this implant I'm going to leave the driver on it, and so the driver is now my anchoring point on the right upper side. So keeping the driver in place is going to provide proper stabilization for my surgical guide. And now I can focus on all the implant sites. Again, not more than 50 RPM and not more than 10 seconds at a time, with a lot of irrigation with saline between the drills, so we can have the proper cooling of the bone. So now we are, after the correct hex orientation, we are sitting the customized provisionals in place. We have to check our provisionals each time we connect a customized abutment, one by one. And now we are filling all the sockets, all the gaps. We have gaps from huge infections we had in these sockets, and we are filling all these bone deficiencies created by the infections with xenograft. These are actually blocks of xenograft with collagen, and we can fill everything very tightly so we can avoid any soft tissue invagination that will lead to loss of contour on this region. You can see how after the surgery, it's really easy to sit the immediate temporary bridge on top of this immediate customized abutments very easily, very fast, and you have a very quick immediate loading in just a question of minutes. What will take hours to achieve on the immediate loading is quite automatic with this already automatic reverse planning with the prosthesis already prefabricated before the surgery. So we could not have time because of patient tiredness to do the soft tissue augmentations. In this case, we did it after in another surgical step. We did the soft tissue augmentation, and then we finalized the definitive bridge in zirconia for this case after a few months. So in my experience, what I see that is working really well on the system that provides this two piece, the precision and predictability of the system. It relies a lot on the accuracy of the data merging of the proper software that DIO team is using, and also the accuracy of fit that I see on the drills on the seals. You can see in the first video, in the last video, how I even had to use the crown removal, a crown removal tool to get my drivers out of the surgical guide, because the accuracy of fit on the drill on sleeves is so tight, is so fit, that a lot of times I see this friction that it's including difficult to remove the driver out of the sleeve, which is actually good. It's quite comfortable for me to understand how this is so fit and so accurate. So when I'm comparing my planned implant sites and CVCT in the reality outcome, the real outcome I have after the surgery, I see this very consistently. I see always how the final outcome after the surgery is really matching what we are planning on the CVCT before the surgery, even for more delicate cases like this, where we have an immediate implant at the premolar, a lower premolar, very close to the mental nerve. If I wouldn't have such predictable system, I would not risk such immediate implant, but I can risk it because I see very consistent results. So another case where we can see how we have a posterior bridge with a huge ridge deficiency. We see how we are lacking soft tissue in width and height at the same time, but the bone situation is not so bad. So we see that a bridge from 13 to 17. 13 is failing because of subgingival caries, and 14 is the root is broken, and so we need to rehabilitate this patient again, multiple implants, multiple teeth, and so I want to be helped by a surgical guided system. So I will plan implants at the sites of 13, 15, and 16, but it's difficult to do these implants because you can see on the 13 how we have a huge apical infection, chronic infection. So the bone deficiency is quite large. So I have only a minimum apical bone to work to get my implant stabilized at one time at correct position. And I have to remember that this patient wants to have fixed teeth from the very beginning of the treatment. She's refusing to use removable prosthesis or being without teeth for several months after removing all these roots. So I have to provide immediate implants and immediate loading at the same time. So this is the remaining bone apically on 13 is very few, so it's going to be difficult to achieve the correct 3D position of the implant if it's not guided, digitally guided. And on the posterior at 15, you can see how the ridge is a knife edge ridge on the coronal part, but at the same time, if we realize where should be the margin, the final margin of this tooth, you can understand that our implant has to be submerged 3 to 4 millimeters. So if it has to be submerged 4 to 3 millimeters, it doesn't match the top of the ridge. So I will have to have something that guide me to understand what should be the correct deepness of the implant. And on and on 16 we are facing the same. To have the correct deepness of the implant, we have to submerge 2 millimeters my implant. So having these different levels of implants according to the bone original position, and having such an immediate difficult implants at 13, I want to have a digital guided system to have the correct position of the 3 implants. So this is my surgical stance after this correct planning with the DIO Navi team. We were setting the correct margin of the teeth. We didn't want to be fooled by the original soft tissue position, which was a big deficiency. So we want to set our mock-up, and the merging with all the treatment with the mock-up is really important to have the correct margin of my final restoration, so I can have space to augment the soft tissues around my prosthesis. So we do the removal of the roots, of the failing roots, but we are in conditions to preserve a buccal shield. So we are doing socket shield technique to help preserve the ridge contour on sides 13 and 14. By the way, of course, we have to remove the apex and the palatal part of these roots to clean all the sockets and get rid of the infection on 13. So now I'm doing a palatal incision on the edentulous area of the ridge, and this way I'm going to move all this keratinized tissue buccally, because I don't want to waste this keratinized tissue on a flapless surgery. In my opinion, we don't always need to do flapless surgery. Even though it is digitally guided, I want to use the digital guided surgery to have the best outcome of the implant positioning, but a lot of times I have to do minimal flaps, minimally invasive flaps, in order to save soft tissue and to be able to have a minimum flap that will allow me to also do my regenerative procedures and augment the ridge as it is needed in this case. So with this apical reposition and flap, I can move the keratinized tissue buccally and save this keratinized tissue around my surgical stance. And I will also have the possibility to move keratinized tissue buccally and augment the ridge. So now we will do, I think I will speed up a little bit so we have time to talk about everything. So this is the correct protocol of drilling that we already know for this system. Doing all the protocol of drilling at the sides of 15 and 16. And now we will place the implants. It's very important to place the implants through the guide, so I will have the correct positioning, 3D positioning, in a case where the position of the implants were not standard according to the original crest. So now after implant positioning, we are accessing the primary stability of these implants, and only 15 and 16 have primary stability to immediate loading. The element 13, due to the lack of bone, was not achieving initial stability enough to be loaded. So I will not load 13. And now you can see that I'm harvesting connective tissue from the opposite tuberosity, which we had a very nice, generous tuberosity, which we can depithelize outside the mouth, and then we will get a very thick, huge block of connective tissue, very dense from the tuberosity, that fits perfectly on the crest that needs to be augmented. So this horizontal and vertical contour that was lacking around 15 and 16 is going to be rebuilt due to this connective tissue block from the tuberosity. We are stabilizing it on the palatal part, crossing buccally the periosteum, piercing again the soft tissue on the buccal part, and coming again from to the palatal side. And now we can stabilize only with one suture this connective tissue graft on the correct position that is going to provide an 3D augmentation of soft tissue right on top of the crest. And now we just need to immobilize the apically repositioned flap with very gentle sutures without too much compression. We just need to immobilize this keratinized tissue buccally without compressing the ridge, without compressing the sutures, because we want to keep this tissue aside, and the provisionals are going to occupy this position, occupy this space, and it also helps to augment the ridge in certain way. So I risked a little bit with this immediate loading because I couldn't load the implant on 13, so I could load only 2 implants, and this mesial cantilever was completely out of occlusion. It was reinforced with metal after the immediate loading, and with this metal reinforcement and relieving the pressure from the occlusion, we can have these provisionals to survive perfectly without further risks for the next 3 months. So you can see how I'm doing the immediate loading. You can see how the emergence of my implants is perfectly positioned according to the prosthetic planning, and you can see the provisionals in place after the healing, after the surgery, I'm sorry. So after 3 months, you can see on the OPG the bone healing around the implants, and now we can access to my implant on 13 that is already osseointegrated. So I connect implant 13 after 3 months to my provisionals, screw return provisionals, and this is the nice new contour of the ridge due to the soft tissue augmentation and the preserving of the tissues. And now we will manage the critical contours according to the principles of critical and subcritical contour described by Ansu and Oscar Gonzalez. So we will create the proper sealing of the soft tissues to this prosthesis by changing the subcritical contour from concave to convex. As we know, it's important for good hygiene and tissue support. So I try to do this digitally, but in some ways I still find difficult to get the proper understanding of the behavior of the tissues if I try to do this subtractive protocol on the digital system. The CAD softwares still don't help me to understand if I'm pressing too much, if I'm pressing less, what is the final contour I'm achieving. I feel hard to see what I'm really doing in this system. It can be easier, it can be quicker, but it's not the same as if I'm doing in the cast model. So when I try to do this on the cast model, because it seems to me easier to understand and easier to control, you can see that we are just doing normal impression. We are just copying the first provisionals, so we can have a copy of the first provisionals. And now you can see the cast model with the gingiva without any type of management of the soft tissue profiles. And now you can see it after the scalloping, doing the scalloping on the artificial gum of the cast model. So how we do this with diamond bore, we are doing the scalloping, we are doing the sealing that we want to see happening on the soft tissues in mouth, because it's important to have better papilla, to have better support from the soft tissues and better hygiene at the same time. So doing this in the cast model, for me, it's so much easier to understand what is really happening, the correct deepness I'm applying on this artificial gum, and I can't quite see the same happening on the CAD system, and that's why I'm still doing this part analogic. After doing this on the cast model, I'm scanning the cast model, and so I have everything inside the software, and now everything goes digital. We scan the cast model, we scan the provisionals, we do the proper matching, and after this proper matching we can have a second set of provisionals for these emergence profiles that are going to shape the soft tissue contour. So let's remember that we pass from this initial situation with huge deficiency on the ridge, and we reach this ridge contour. We can see here a nice 3D rebuilding of the deficiency of the crest, not only by the proper soft tissue augmentation, but also by having the correct emergence of all the implants, which is really important. So you can see an overview before and after the emergence profiles. You see the nice new contour of the ridge on the dentless area where the soft tissue augmentation was critical. This is the power of the soft tissue augmentation that we can see with no other procedures. And you can also see the perfect sealing of the soft tissues by the prosthesis. You can see that it is happening on the mouth, the same sealing of the soft tissues that we were planning on the cast model. And now we are in conditions to provide and deliver the final restoration. Zirconia bridge is going to fit perfectly on these emergence profiles. And of course, on this, we are taking advantage of a very well-known CAD/CAM technology. There is a huge amount of papers and scientific and clinical evidence on the predictability that this tool is giving us, especially for the prosthetic treatments, not only for the surgical part, but especially for the prosthetic treatment. It helps me a lot to be predictable, because a lot of times we are facing cases like this in which we'll have to step into different stages of procedures, and I don't want to lose information from one step to another. I don't want to begin all over again after a different stage and start everything from the scratch. So I want to save information from the teeth from one step to another. So this is a very tragic case, if I might say. This is a patient which is having all her teeth failing by severe periodontitis. These are all terminal teeth, all terminal dentition. She was really aware of that, and so she wanted to replace her teeth by implants, by implants, by fixed teeth retained by implants. So I planned at first to do this in a staged approach, because I had huge, very damaged soft tissue. I had contaminated coronal tissues, not only bone but also soft tissue was really contaminated in the most coronal part. I didn't want to use pink gingiva. I didn't want to use artificial gums. I wanted to have the proper white balance, pink and white balance of the restorations. And so first I removed most of the teeth and used only some teeth has pilers for cemented retained bridge over teeth. So we left all the other sides healed in order to get the best possible soft tissue and bone for the implant surgery. So after waiting 3 months after the extractions and cleaning of the sockets, 3 to 4 to 6 months, I can't remember quite well. So we have now better conditions on the soft tissues and on the bone. The most of the infections are healed, and now we can do our surgical, our implant surgery guided, and so we can achieve the proper position for my implants. And of course I have to do the soft tissue augmentation buccally, so I have the proper contour of my soft tissues horizontally. So you can see that with 2 connective tissues from the plate, I'm able to graft from the premolar areas to the anterior areas, and this way I will have the proper horizontal contour of my ridge to match the desired teeth. This is the healing after 1 week of the immediate loading, and when we wait 3 months, we see the healing around my first provisionals. My first provisionals are only sustaining the critical contours. They are not still sealing the soft tissues. They are not still doing any kind of pressure on the augmented soft tissue contours. And this is this is the planning that we have for the second step of provisionals. This is what we want to achieve. It's important to scan the first provisionals in order to have a starting point, so we can have a starting point on these first provisionals, and then this will help us to go through the second stage of provisionals, where we will do our prosthetic soft tissue engineering, remodeling the emergence profiles, and we set the second provisionals after this. So after the soft tissue healings with the second provisionals, these scalloped emergence profiles, we have to maintain them, and we have to communicate this with the lab technician. And it's really difficult to have this proper communication with the lab technician, to have the proper information about the volume and the anatomy of the soft tissues. So is there any full digital method to achieve this? Yes, of course there is. This is a method that I have been doing with a Brazilian dental technician, which is called Alexandre Andrade. He's doing in the CAD software, he's at first only scanning the cervical part of my second provisionals, which the soft tissue contours are perfectly matching the provisionals, and this way we are producing a negative impression inside the software. So this is my artificial gingiva that is already inside the software, and so everything that we will produce according to this is going to match perfectly with this contour, because a lot of times when we scan an artificial gum on cast models, we don't have quite the same. We have some deviations between what we have in mouth and what we achieve in the milling machine. So this way we have a final bridge in zirconia that will match perfectly the scalloped contours of the gingiva, and we will have a perfect matching. This is the moment of fitting the definitive bridge on this managed emergence profiles, and now you can see the proper fitting of the final bridge on the soft tissue contours, and you can see how the bridge is emerging from the natural gums, like if they were the natural teeth for this patient. You can see the beautiful transformation before and after on this bimaxillar complete implant treatment, and of course this is life-changing for a patient. And you can see also the final OPG at the end of the treatment. So I will end now, and I will want to share with you a very nice video that actually it shares my vision about the digital tools in our daily dentistry and also in our daily lives. This is a video from Christian Krohn. It's not my original video, but it shares a very beautiful opinion about it. So thank you very much for your attention. Thank you for being here in such moments, and I hope it was helpful for you. And these are my contacts, so if you have any doubt or if you want to discuss any subject, feel free to do it. Okay, take care and stay safe.